Hi, I'm Charlotte. This is going to be a presentation on chest x-rays for students starting with respiratory placement at Leeds Teaching Hospital. It'll be a brief overview, just looking at different sort of pathologies and chest x-rays that you can come across. The most important thing to note first is that you're looking at the correct patient, the correct time and the correct date. You can see if the patient is in, or the patient's position, so if they're sitting, standing or in supine. Chest x-rays are normally reported. You can find that the doctor's report, which will be next to it, next to the x-ray itself. And you can do different things like change the brightness and exposure, look at different x-rays, look at two x-rays side by side, and bring up all the other previous images they've had. So from this one, you can see the different anatomy you can see within or from the chest x-ray. So some things just to note before we actually go through systematic way of reading chest x-rays and the actual anatomy itself is, so firstly the projection. So you can have something called an AP, which is anterior to posterior projection, or a PA, which is posterior to anterior projection. A PA is our normal sort of x-ray that we have. The patient is usually standing up and the x-ray beam is passing through the patient from posterior, so from behind, to anterior, to in front. Chest x-ray is viewed as if the patient, or as if looking from the patient from the front, so being face to face with the patient. You can also do lateral films in a PA projection. AP projection, so from anterior to posterior, is usually done if the patient is too well to stand and therefore needs a portable x-ray. The chest x-ray is still viewed as if looking at the patient from face to face. The main thing to note is that the heart in an AP view, so anterior to posterior, will be magnified. So magnification is exaggerated by the shorter distance between the camera and the patient with an AP view. The second thing to think about is film exposure. So this is basically what you can see within the image itself. You should be able to see the first 10 ribs in, or 10 ribs posteriorly on an inspiratory film. You can differentiate items on a chest x-ray due to the different densities of material. So, for example, black on an x-ray is air, dark grey is fat, light grey is soft tissue, and off-white is usually bone, and bright white is metal. Finally, rotation. So the medial ends of the clavicle should be equidistant from the vertebral bodies. Rotation alters the heart size and shape and can give a skewed view of what's actually going on. The ribs should be smooth and the intercostal spaces should be equal on both sides. So again, this is just another image which kind of gives you the appreciation of the number of different ribs that you can normally see in a normal chest x-ray, some of the anatomy, so you can see your left and right hemidiaphragms. On your right side you have your liver, on your left side you have your stomach and your gastric bubble, and then you can see your cornea where your trachea bifurcates. So when you're reviewing a chest x-ray, you can go through a systematic method of A to H. So starting with A, so this includes your airways. So we're looking at if they've got an additional airway in place, so such as an ET tube or a trachea, and if they've got a shift of their airway. In terms of lung volumes, during inspiration we're looking for the 10th or 11th of the posterior rib to be visible, and yeah, airways can be affected by position, so if they're in AP, PA, sitting or supine. B, we're looking at the bones and soft tissue, so we're looking for symmetry, looking to see if there's any fractures, any swelling or any subcutaneous air. C, we're looking at cardiac, so the clarity of the heart border, looking for the cardio and costophrenic angles and the sharpness of those angles. D, we're looking at the diaphragm, so we're looking at the hemidiaphragms. These are normally equal, so at the same level. Sometimes the right side can be slightly higher than the left, and that's due to the liver. The shape, so diaphragm might be flattened slightly. So if they're bilaterally flattened, this could be due to something like chronic asthma or emphysema, or if they're unilaterally flattened, this could be the case of a tension pneumothorax or foreign body aspiration, for example. E, we're looking at edges and effusions. So this can be pleural effusions. So for this we're looking at the costophrenic angle and the sharpness of this. Blunting of the angles may indicate a small effusion. So the other thing for effusions are you can look for lateral or supine. So repositioning might displace a small pleural effusion. So if a patient is lying down, it can be a bit more difficult to see the meniscus line of an effusion than when they're in sitting, for example. F is fields, fissures and foreign bodies. So we're looking to check the lungs for infiltrates, so this is interstitial versus alveolar, masses, consolidation, so this can be such as air bronchograms, so pneumothoraces and vascular markings. So we're looking to evaluate the major and minor fissures for thickening, fluid and a change in position, and looking to check for position of foreign bodies. This can include an ET tube, an NG tube, pacemaker leads, central venous lines, or a comment on like previous surgeries. So this can be like a cholecystectomy clips or sternotomy wires. G is gastro, so that's the aortic size and shape and outline of the pulmonary vessels. The aortic knob should be clear and the gastric bubbles should be clearly seen and not displaced. H is for hilum. This is your vasculature. The left hilum is normally higher than the right, and it can also be the widening of the mediastinum. So abnormalities. There are a few different conditions which we look out for to see on X-rays. Firstly, lung lobe and segmental lobe collapse. So a loss of air causes white areas or crowding of vasculature markings depending on the degree of collapse. There could be a compensatory emphysema that could occur in the adjacent lobes, causing spreading of the vasculature markings and increased translucency. The lung fissures might deviate and the diaphragm might be raised. The trachea may be deviated in an upper lobe collapse and the heart might be deviated in a lower lobe collapse. The deviation is towards the area of collapse. Crowding of the ribs is due to decreased movement of the underlying lung tissues. Lines of atelectasis might be able to be seen, classically normally seen along the fissures, and during exhalation on an X-ray could show air trapping or atelectasis, as all the other air out of the lung is out of the lung and that air is becoming trapped. Second one we look for or can often see is consolidation. So that's decreased translucency over an area of the lung without shift that occurs in a collapse. So bronchi may be visible as dark lines over a consolidated area, which would be like an air bronchogram. Might be a loss of hemidiaphragm and lung angles, so an inability to be able to see those. Pleural effusion, so that's a loss of the costophrenic angle, which is replaced usually by a meniscus type line. There's general opacity over the area or over the base of the affected lung or area where you think the effusion is. Lives normally concave, which marks the upper extent of the effusion. And in sitting you can normally note the effusion line or the fluid level. Pneumothorax, so the lung markings do not extend all the way to the edge of the thoracic cage. Beyond the lung edge, there's a very black translucent area which indicates free air. So next one is pulmonary edema. So that's an accumulation of excess fluid in the interstitial spaces. Typical diagnostic would be a bat wing shadow. Edema results in definition with blurring of vascular markings and upper lobe diversion and is prominent upper lobe vessels. And the last one is ARDS, so this is acute respiratory distress syndrome. Interstitial edema producing a hazy ground glass appearance, patchy airspace edema followed by diffuse and extensive consolidation. This is your kind of COVID lung picture that we've been seeing. Okay, so we're going to run through some actual chest x-rays themselves. So I'll give you a few minutes or a few seconds each time, and then I'll let you know what the pathology of each of them are. So this first one is a completely normal chest x-ray. So this chest x-ray is a right basal consolidation and left basal effusion. This is a post-op surgical patient, cardiac post-op. They have small bibasal effusions, atelectasis in the right middle zone, and a small collapse on the left base, which is classified by the sale sign on the left. This is a post-op liver transplant patient. You can note that the chest x-ray is actually a supine chest. They have an ET tube present. They have two right pleural drains and a bilateral interjugular catheter. The left hemidiaphragm is not adequately visualized, and there is maybe partial atelectasis or consolidation on the left lower lobe. So this one is left basal sided collapse. You can tell this with the rib crowding and tracheal shift. This could be chronic with a slightly hyperinflated like appearance of the lungs. So this is a right basal collapse with raised right hymy diaphragm, and there's heart and tracheal shift to the right. This is a moderate left basal pleural effusion with clearly defined lines. Query: there could be a bit of a right upper lobe pneumothorax, as you cannot clearly visibly see the lung markings on that right upper lobe. This one is a massive right pneumothorax. So this one's widespread pulmonary edema with bibasal effusions, has a wet appearance, and your classic bat wing bilaterally. This one is acute lung injury, or your ARDS picture. This is right upper lobe collection, so that could be due to a hemothorax or empyema. This is surgical emphysema, which is on the left more than the right. This one is situs inversus, or your dextrocardia. This one is situs inversus, or your dextrocardia. This is a cystic fibrosis patient, and it's a right upper lobe collapse. This again is a right upper lobe collapse. This one is bilateral patchy consolidation in the mid and lower zone, and is COVID-19.